Your EHR was built for the easy patient. It was built for the patient with one problem, one provider, one visit, and a standard pathway. That is not a cynical read, that is what the system was designed to optimize for because that patient is the majority. But there is another category of patient. The patient who has been to 4 specialists, who has a 3-year history of a condition that does not fit neatly into any single department, who carries a stack of records from 2 health systems, a PDF from a clinic that went out of business, and a story that starts in 2021 and is still unresolved. That is the long tail, and that patient is exactly who Agentic AI was built for. In software engineering, there's a concept called the happy path. The happy path is the most common, most straightforward use case. The scenario where everything goes as expected, where the user does what the system expects them to do, and where the system operates as designed. Software is almost always designed around the happy path. Edge cases, the unusual scenarios, the exceptions, the cases where the user needs something the system was not quite built for, are handled poorly or not at all. Healthcare information systems have the same problem, and it is more consequential there than anywhere else. The happy path in clinical EHR design is something like: patient presents with a specific codable diagnosis, receives a standard workup, gets a standard treatment, and is discharged with a clean summary. That pathway is well supported. The documentation templates exist, the order sets are defined, the billing codes are mapped, the long tail is everything else. The patient with 3 overlapping diagnoses that produce a combined presentation that does not fit any of the standard templates. The patient who has been in the system for 8 years, whose history spans 2 EHR migrations, a health system merger, and 3 different primary care providers. The patient with a complex musculoskeletal condition that crosses orthopedics, physical medicine, rheumatology, and regenerative medicine, and who has never had all of those specialties talking to each other about the same chart at the same time. In primary care, the happy path is probably 70% of visits. In a specialty practice like Pravida, the long tail is the majority of patients. They came to us because the standard pathway failed them. Their complexity is not incidental, it is the reason they are sitting across from me. The OpenClaw Hospital paper I discussed in episode 5 includes a benchmark study that is specifically designed to test how AI systems handle long-tail patient complexity. I want to go deeper on those results here because they are directly relevant to this conversation. The benchmark uses MIMIC-IV version 2.2, a de-identified dataset of ICU patient records, one of the most widely used research databases in clinical informatics. The study selected 100 patients and generated 300 clinical queries across 3 tiers of difficulty. Tier 1 queries are the happy path, structured data retrieval from a single visit. Any system handles this reasonably well. Tier 2 queries require temporal reasoning across multiple visits. How has the patient's renal function trended over the past 3 admissions? This requires connecting data across encounters and reasoning about temporal change. Performance drops for standard RAG systems. Tier 3 queries are full long-tail complexity. Given this patient's history of sepsis, their evolving renal function, and their current medication regimen, what are the key considerations? These queries span multiple care episodes, require integrating clinical context from years of records, and demand a synthesis that no single document in the chart contains. The benchmark comparison pits the manifest-guided retrieval architecture against a metadata-filtered RAG baseline. On Tier 3 queries, the manifest-guided approach achieves 0.846 recall versus 0.701 for the baseline. That 21% recall gap is the quantitative representation. In clinical terms, a 21% recall gap on a complex case synthesis means the AI is failing to surface roughly 1 in 5 relevant data points from the patient's history. In a patient whose current presentation is critically dependent on understanding what happened to them 3 years ago, the prior reaction to a drug, the prior imaging, that gap is a safety event waiting to happen. Let me give you a concrete clinical case that illustrates what I'm describing, drawn from the kind of patient I actually see at Pravida. A patient comes to me, a 55-year-old former recreational athlete. They have bilateral knee pain, worse on the right, that has been progressive over 4 years. Their history: right knee arthroscopy in 2021 for a medial meniscus tear, followed by a course of physical therapy that helped initially, but they plateaued. In 2022, they saw an orthopedic surgeon who discussed total knee replacement but recommended against it, given the patient's age and activity goals. In 2023, they saw a rheumatologist who found elevated inflammatory markers, CRP and ESR both elevated, but no evidence of a specific inflammatory arthropathy. In 2024, they tried a cortisone injection series with one of their prior providers, got temporary relief, and then returned to baseline. This timeline illustrates the patient's longitudinal clinical journey over the past several years. When this patient comes to me, I need all of that history to make a good decision. The arthroscopy report tells me the state of the joint at the time of surgery. The orthopedic surgeon's note from 2022 tells me why replacement was deferred. The rheumatology workup tells me the patient has elevated inflammatory markers. This changes my calculus about platelet-rich plasma candidacy and adjunctive treatments. The cortisone response tells me about the patient's biology and pain mechanism. In today's world, gathering that information takes significant effort. Some of it comes in as faxed PDFs. Some of it requires me to call prior providers' offices. Some of it the patient partially remembers. I am building the picture in real time, during the consult, from incomplete information. With manifest-guided longitudinal memory, those records would be pre-organized by care episode, with the key clinical findings extracted. The arthroscopy report, the orthopedic note, the rheumatology workup, all of them navigable. My starting point would be an organized clinical synthesis. The shift from manual record synthesis to an agent-organized clinical summary is transformative for physician workflow. And that is before we get to the regenerative medicine specific decision. Is this patient a candidate for PRP, for BMAC, or a different intervention altogether? That decision requires current imaging, lab markers, and understanding prior treatments. An Agentic OS surfaces the relevant clinical decision framework automatically. There is a second dimension of long-tail complexity that I want to address separately, the cross-specialty problem. There is a second dimension of long-tail complexity that I want to address separately, the cross-specialty problem. Orthopedics has a knee pain template, rheumatology has an inflammatory joint disease template, PM&R has a functional assessment template. Regenerative medicine, which sits at the intersection of all three DOS, does not have a template in most EHRs, because it is not a formally recognized specialty. What this means in practice is that every regenerative medicine encounter involves a documentation workaround. I am building from scratch or using a hybrid approach. That documentation friction is not just a time cost, it is a quality cost. Data captured in non-standard formats is harder to query, aggregate, or use for tracking. Regenerative medicine serves as the critical intersection of orthopedics, physiatry, and rheumatology. The composable skill library approach in OpenClaw Hospital is the architectural answer. It lets a practice build skills that match their actual workflow. A Pravida-specific intake skill that integrates orthopedic history, physiatry functional assessment, and regenerative medicine protocol design. Those skills can be built, tested, and versioned. This is the opportunity to build on the composable infrastructure and create clinical AI tooling for your specific practice. I want to close this episode with an argument that I think often gets lost in the conversation. The access equity argument for agentic AI in complex medicine. The long-tail patient coas with multi-system complexity and years of unresolved illness is disproportionately underserved by the current system. Structural barriers to comprehensive care are highest for complex patients. Getting records in one place and specialists to communicate is hard. Getting the time for a physician to do a proper synthesis consultation is scarce and expensive. This visualization highlights the inverse relationship between patient complexity and the accessibility of comprehensive medical care. The Tsinghua Agent Hospital data, 10,000 simulated patients trained to residency equivalent performance, points toward an access argument. The Tsinghua data demonstrates how specialist-grade clinical synthesis can be scaled across a digital infrastructure. An agentic system can organize records and present structured summaries to primary care physicians or rural telehealth specialists, compressing the access gap. For Pravida, this has a specific implication. Our expertise in regenerative medicine is currently limited to patients who can come to Atlanta. By encoding specialist protocols into an agentic core, we dividend that expertise across the entire clinical network. Through telehealth and partner practices, this tooling gives referring physicians access to specialist knowledge. That is the access equity dividend. The long tail is not a niche problem. It is the problem of everyone whose history matters, where the answer is in the pattern across many notes. Today's EHR was built for the happy path. Agentic AI is the first technology designed for the long tail. This is a fundamental shift. Next week, I'll walk you through a concrete playbook for applying this architecture in your own practice. I'm also releasing the Pravida AI operating system map as a free template to help you get started. I'm Dr. Trevor Turner. This is the Medical Operating System.